Yeah, we are live, man.
Yeah, good evening, everyone. So of late, we have been seeing and hearing more and more about microwave ablation by Dr. Jay. He showed a live surgery yesterday with a lot of practical points as to how he is doing. And also they had a blast series a couple of days back where it was covered almost extensively. But today's session is only about the fertility aspect of the adenomyosis cases where he has done microwave ablation, or what are the nuances that all fertility experts should follow to get the maximum benefit out of microwave ablation. As we all know, adenomyosis and adenomyomas are very frustrating, and the outcomes are not as we would like them to be, especially after surgical management. And as clinicians, we are also hesitant to suggest adenomyomectomy or repeat adenomyomectomy in many such cases. So today, Dr. Jay will tell us about like how microwave ablation can be utilized in these cases where fertility is a priority. And if we can take home a few points which will help us in our practice, then it would be great. So shall we start with the Q&A directly, or?
Yeah, we'll straight start with Q&A only, madam.
Yes. So I have a few questions, which I think because the theoretical part of it, maximum, I think they discussed last time. So we have accumulated these questions which were asked across like some 60-65 groups. So how can we spare the EMJ? That is the endomyometrial junction. I think we discussed about this, the severity or the outcomes in adenomyoma, where
Yeah.
we were thinking the size of the adenomyoma, location of the adenomyoma, vascularity of the adenomyoma, the size of the adenomyoma, and endomyometrial junction. So among all these, endomyometrial junction is the most important factor when we talk about the implantation rates or even about the fertility aspect of that woman. So how do we like maintain the endomyometrial junction, the integrity, or
Yeah.
how we can improve? Yeah, sorry. Yeah, go ahead.
Yeah. So I think if you see now, madam, uh, I think you can see the whiteboard. Can you see it?
Yes.
Okay. So what is important, no, madam, for all of us to understand is that as far as adenomyosis is concerned, no, see, this is our standard. This thing, madam, isn't it?
Hmm.
Uterus. This is how a standard uterus is going to look like. Okay. Adenomyotic uterus is going to be something like this. See, right? The problem about endomyometrial junction, the best thing to look at the endomyometrial junction, in my opinion, is to start with a hysteroscopy in these cases, which is what we do. If the endomyometrial junction is involved, the hysteroscopic appearance is going to be something like this, right? If it is very close to the endomyometrial junction, you will see that, and you will realize that the benefit, if the endomyometrial junction is already involved, of doing a microwave ablation is going to be less than 20%, madam, is what we have seen. Okay. The good thing which you can understand and how can you spare is that, listen, when you put a microwave ablation, when you put this probe inside, no, this probe goes inside actually. Let's say it has gone inside the adenomyoma, then it depends upon your settings. Okay. How much settings, that means what is the what? I mean, what is the power of the ablation? What is the time of the ablation? Okay. And what is your distance from that junction? Because the ablation is going to occur in this window. Okay. It is going to occur something like this. All right. It will keep on occurring like this. So when the ablation occurs in this window like this, your wattage and your time is going to be the important thing, which is going to sort of preserve the endomyometrial junction for the patient. And if you are able to preserve the endomyometrial junction, obviously, I mean, that is the thing. If you preserve the endomyometrial junction, only and only then you are going to be able to give the patient some benefit out of this procedure.
Okay. So, see, I mean, does it matter about the depth of these lesions where, like, see, you showed it, it was almost in the mid posterior aspect of it, which is very close to the endomyometrial junction. Till
Yeah.
what millimeter you think you're safe in doing
Here,
it?
madam, see, if this is a focal adenomyoma, can you see this new diagram which I drew right
Yes.
now?
Yes.
Your focal adenomyoma, no, madam, one thing you have to be careful while doing the ablation is that at any given point in time, you have to be 5 to 7 millimeters away, okay, from the endomyometrial junction. No matter what you do, you have to be 5 to 7 millimeters away. If you are 5 to 7 millimeters away, that means your probe cannot be in the endometrium. Understanding?
Yeah.
It has to be approximately 5 to 7 millimeters away from the endometrium, and that is where you need to stop your ablation. Okay, because if you keep on going there, no, then the arborizing vessels which are present here, na madam. Okay, all these vessels will get ablated. Okay, and it will become like a patchy, shady endometrium. That will not be a very good outcome for the patient. It requires some amount of ultrasound skills, which we shown in that Facebook live video, madam. Like
Yes.
how we are exactly monitoring it. I think that is something which is very important, which will help people preserve the endomyometrial junction.
Yeah. Also, I mean, you said in the yesterday's surgery, or I think, I don't know, the IUI catheter you will use to
Yeah,
maintain the cooling
yeah,
effect.
cooling. Yeah, madam. See, it is like this. See, this is again, I'm drawing all uteruses, adenomyotic uterus only. So you put the IUI catheter here, madam. Okay. The IUI catheter, no, what you are supposed to do is just suppose this is just IUI catheter. You just connect the IUI catheter to your IV set. Okay, cold IV set. It will keep on passing small quantity of water inside. Okay, so there will be dispersion of heat just in case you have come very close, no, to the endomyometrial junction. There will be dispersion of heat and that water will keep on seeping out. No, madam. So it will prevent any form of thermal damage which occurs to the endomyometrial junction.
So this you're doing it for all cases or
Not
only?
at all. I've stopped doing it for any case now.
Okay, this was only as a learning curve where you
As
didn't.
yeah, when I started, madam, I was doing.
Okay, okay. And how do you select these fertility cases? I mean, is there any strict criteria that you have?
No, I see. The case selection is very simple, actually, madam. I will just again draw and show because this is the picture which we commonly see in adenomyosis. Okay. So what we normally see, no, we see something like this. See, this is the uterus. Okay, this is our adenomyotic uterus, madam. And endometrium is like this. See, correct? This is
Correct.
like the curved endometrium which we have. And the adenomyosis is going to be somewhere here, madam, actually. Here.
Yeah.
This is our adenomyosis. So when I look at it from the point of view of getting this thing done now, it got erased. No, it's here only. Sorry. So when I look at it from the point of view of doing adenomyomectomy, doing this adenomyomectomy is impossible without damaging this part of the endometrium. Understanding? You have to open this endometrium so that you can go in this plane and remove this adenomyosis, isn't it? Same, simultaneously, you should understand that if this length of the uterus, okay, with this focal adenomyosis has exceeded 8.5 centimeters, no, madam, then usually all our GnRH agonist, which we all use, no? We use GnRH agonist. Some of us now have switched to letrozole plus registrone. Some of us are using something else which somebody has told us. But answer to the question is none of it actually works very nicely because your size of the uterus never comes down to 6 centimeters, 7 centimeters, and all these types of things, isn't it? Because it doesn't come down to that, we are in a trouble. So these are your cases. These are your absolutely, this is case scenario number 1, which I have just drawn here. The case scenario number 2, I'll just draw down below. I would just request people to stop scratching on this whiteboard, please. Yeah. Keep your hands away from your phones, guys. The second case scenario is this, madam. This is a huge adenomyosis, right? This way. This is a huge one, right? And in this adenomyosis, so definitely size of the uterus is only more than 10 centimeters. So any which was GnRH agonist and letrozole plus registrone is not going to work, madam. So this is actually case number 1, this, and case number 2, this. But in our practice, madam, if you are a fertility consultant, in 1 or 2 months, you are going to get one such case which is belonging to case number 1. And in a year, you may get 1 or 2 cases belonging to case number 2. Unless you are doing a lot of endometriosis surgeries, getting case number 2s is not very common. Okay, those type of patients are in so much pain that they are not going to wait to see a fertility consultant. They want to get rid of their pain first. This case number 1 are the patients who are bearable pain. So out of their, feeling to have a child, they will be willing to bear this much additional pain, something like that. And as a result of which, you are going to get that type of patient very much commonly, madam. which is why in fertility you will see case number 1, which I just printed, much more commonly than the other.
Yeah. And see this huge uteruses, the case number 2, the type what you said.
Yeah.
See these ones, I mean, you think, I mean, that's such a big uterus. I mean, you do microwave ablation and you think the fertility potential, are you going to really like, I mean, enhance or conserve in such cases? What is your thought?
See, it will act the best in case number 1, madam. That also I will tell you. It will act the best in this case. Okay. In case number 2, I personally still believe that I should be doing adenomyomectomy. Okay. I personally believe this because my adenomyomectomy outcomes, traditional adenomyomectomy with laparoscopy outcomes are actually fantastic. Okay. And what I will be able to achieve is I will be able to knock out this entire window here like this. I will just knock this out. But the only compromise is, no, madam, in this adenomyomectomy, which I do, and we all know this, the compromise to tubes is very high. Okay.
Correct.
You may end up losing the tubes, madam. So that is the option. If the patient is not willing to compromise on tubes, then in this case also you can offer them a microwave option. If the patient is willing to lose the tubes and is a fertility patient, wanting to go ahead with IUI, wanting to go ahead with IVF, then no problem in doing adenomyomectomy is what I think.
So is there a option of combining both like microwave ablation
You
and
can't do it, madam. No, it's not.
adenomyomectomy in the same
No,
city?
can't do it, madam.
Okay. And
But we are now doing ablations for recurrent adenomyosis. I mean, as you know that I think get a huge volume of one adenomyomectomy done, no? Because primarily when an adenomyoma goes to a consultant, they would want to call somebody, get it done and at least experiment, right? So once that experimental window is finished, no, madam, and when that adenomyoma has recurred, okay, that is the situation where microwave ablation will be very good because already, see what happens in an adenomyomectomy is even if you do a great adenomyomectomy, na madam, there will be adhesions there, right? And because there will be adhesions there, you first have to go inside, do the complete adhesiolysis, which even the primary surgeon who has operated will not be willing to do, madam. Because those are bad adhesions, no? And remember, microwave ablation, the bottom, I mean, if I write microwave ablation here, no, okay, the absolute equivalent to get microwave ablation done is adhesiolysis. If you don't do adhesiolysis, you are dead.
Dead in terms of like, the
Complication.
complications with regard to the bowel injuries, ureteric.
Yeah. I'm going to show you. Yes. I'm going to show you. See, in Maharashtra, we are only 2 people who are doing microwave ablations. Understanding? And there are some more people, 1 or 2 scattered here and there across our country of India. Okay, so I'm going to show you one excellent complication which is happened in South India somewhere. Okay. Following microwave ablation, the person has not done adhesiolysis. Okay. And there is a 7 centimeter rent on the bowel.
Okay.
The whole bowel, right from upper rectum to lower rectum, okay, has been torn apart.
Okay.
Yeah. And the patient landed up with fecal peritonitis. Ileostomy was done. And we have done a segmental resection after that. So I'm going to post about it.
Okay. And this ablation, can you do it laparoscopical? I mean, guided by laparoscopy, which I saw yesterday.
Yeah, laparoscopic guided ultrasound.
Yeah. So can you do it transvaginally, just ultrasound guided, like how we do the pickup, like trans uterine, if non-accessible ovaries are there, like that?
Madam, in order to put the probe here, no, like this, you will end up ablating this part.
Why? I mean,
because now, madam, the probe will ablate along its entire tract.
It is not insulated?
It is insulated, madam. But the heat dispersion, no, is mainly in this radius here, where it is at the tip. Okay. And there is some heat dispersion which will occur along the tract. Okay. So this part, no, madam, internal os. High chances that the internal os can get damaged if you go transvaginally. Of course. If in case your probe has entered inside the uterus for more than 2.5 centimeters, then that risk goes away, madam. Because that first 2.5 centimeters of the probe is critical. Understanding? But these adenomyoses are going to be located very close and just above that internal os, madam.
Correct.
Somewhere here. Correct, no? See, somewhere here they will be located, madam. So At the moment in my practice, till I don't cross around 1,000, 2,000 cases, I don't want to take that risk of going transvaginally because I am very much worried about giving outcomes at the moment. So I want to go trans abdomen. I mean, I want to go laparoscopically. See, if Visma is putting the probe here, no, madam, for this ultrasound, okay, I am putting the probe from up, no, laparoscopy guided. My probe is coming from here, like this somewhere, correct? So this clarity with our synchronization we have achieved very nicely. So we are able to compromise and we are able to put, ablation even in this region, close to the fallopian tube. Small adenomyoma here, we will save the fallopian tube. In that situation, madam, we'll 100% put water because like SSG is there, no, madam. We want to delineate that fallopian tube. So once we delineate the fallopian tube, our probe will grow right beside that, understanding, and we will ablate. So I am going to share outcomes. Let 2-3 of my patient reach 7-8 weeks. I am going to share outcomes with natural conception post microwave ablation.
Okay. And do you think it is operator dependent or anybody can just do it? Like, I mean, you do the adhesiolysis because majority of our endoscopic surgeons are able to do a decent adhesiolysis. So all it takes is just about like, getting that machine, buying the probes and start poking it inside and start doing it.
Yes, madam. Yes. So basically it is dependent on how good your adhesiolysis is. If you have knocked out everything right, ureter till the tunnel, bowel till below, okay, fallopian tubes, ovarian fossa, everything has been knocked out, then the outcome will be good, madam. That means you will be able to do a very good, you will be able to give the patient a good outcome, madam.
So how about the fever or the infection chances like discharge?
Fever happens. Post-operative fever is common. That is because of the microwave ablation causing coagulative necrosis inside the tissue. So once the microwave ablation causes coagulative necrosis inside the tissue, it can give rise to post-operative fever for the next 12 to 14 days.
And why do we suspend the uterus? I saw you do it like, I mean, very diligently, which you never
That is
bothered.
to ensure that there is no bowel coming there.
As it?
See, bowel adhesiolysis is done, so bowel will fall back, no, madam. And when you suspend the uterus, there is naturally an air gap which gets created between the uterus and the bowel, isn't
You
it?
think
In
so?
a headlock
But
position.
bowel will be mobile only, right? I mean, wherever the uterus
Post
position.
surgery, madam. Post surgery. This post surgery, once deflated, it can come, na. I am talking during the surgery. There is a big air gap which comes between the bowel and the uterus.
Yeah.
That situation. Only intra-op I am talking.
So for intra-op, you can always like, use the manipulator and antivert it.
But madam, what if you want to use that water quotient inside? Then manipulator has no role.
So, I mean, do you do hysteroscopy in all cases before you actually go ahead and do this? And
Mandatory.
why do you do the
To
hysteroscopy?
look at the endomyometrial junction, madam.
Okay. So what are the points that you look for? I mean, do you look for like any craters, any cystic?
Distortion. Basically distortion. Simple. If there is an adenomyometric distortion in the endomyometrial junction, we'll tell the patient that the outcome is not going to be so great.
So how many cases which you have done have turned out pregnancy positive in the last month?
Madam, this month we have had another 4 more who have become urine pregnancy test positive with beta HCG more than 2000. That means on the repeat beta HCG follow-up. Okay.
So that is
And
with IVF, right?
Only IVF. Yes. These are all IVF cases. These are all patients who have at least failed one IVF cycle in the past. All patients who are having focal and diffuse adenomyosis, whatever, whichever category, but focal and diffuse adenomyosis both.
So how long did you wait to do the IVF in such cases?
When we started, no, madam, some people we took off in 45 days. But now we have decided since September 4th or no, September 10th, I think, onwards, we decided that we will now do all in the month of December. All of them we'll do in the month of December. So maybe 30-40 we will do in December together.
So that's because you wanted that 12 weeks gap for the.
Yeah, we wanted some more amount of volume reduction, madam. See, more the volume reduction, better the pregnancy rates.
So do you add letrozole and registron or Dronis P post microwave ablation?
Nothing. It's gone. No, that tissue is destroyed, madam. What you will add?
It's like keeping that myometrium in a microwave, you think?
Sort of, no. It is that this is very strong concentrated heat, no, madam. Like I did not, I don't know. You were only laughing. No, I gave that example. No, if I have to heat children for milk, I mean, if I have to, sorry, heat milk for the children, I will keep that glass inside that microwave only for how many seconds, madam? 20 seconds. Understanding? And in 20 seconds, milk will become very hot. Understanding? Even if you take it from the fridge, same thing happens in the uterine tissue.
Okay, you tell me this. I mean, it's been available from quite some time, as in with the liver surgeons and all that. Why
Yeah,
do
yeah.
you think like it was not very popular among gynecologists? Like they could have used it for even fibroid, right? I mean, submucous
So
fibroid.
people are using it. Our colleagues in China are using it for fibroids distorting the endometrial cavity, and they have absolutely fantastic outcomes out of that.
Mm.
Absolutely fantastic. If you see, there are some Chinese papers available. You can translate them in Google into English, okay, and you will understand that our colleagues in China have absolutely fantastic outcomes of that.
And do you think, like, I mean, I don't know, I'm just asking, and nothing against the Chinese. So do you think, I mean, there can be a better models, or like there is any comparison between a Chinese model, the one which is available right now, to a standard like a Germany made or
I
US
have
made?
not seen so far, madam. In the market, there are two people. Both of them are Chinese. I am
Okay.
yet to see a non-Chinese made microwave ablation machine. I'm sure there must be one, but they have not come to me as yet.
But don't you think the Westerners would have like jumped to it because anyway they're not too pro for surgical management. So this would have been a great alternative, especially in fertility sparing.
I don't know. It's a very surprising thing because I personally think that most of the countries, no, like somebody had posted some British guidelines today morning. Remember?
Yeah.
British don't even have an endometriosis unit. What they will operate? Okay, so even if you give them ruptured endometriosis, they will want to put a needle and aspirate it out. They are dumb. Okay, so we should not go by such type of guidelines. No,
Okay.
I personally think.
Yeah. So see, this is relatively new. I mean, we have heard microwave ablation in the past 40 days, probably more than what we had heard in our entire lifetime. Because
Yeah.
you keep putting it every day and you keep showing either in your live surgeries or in your ultrasounds or something, somewhere Instagram, something will be happening with you. So in such things like, I mean, suddenly you find this new technology and you start doing it. So is it like a proven therapy? How do you take the consent? Like how we do it for LIT, how we do it as stem cells?
Consent for microwave ablation, as far as ablation is concerned, is proven. Okay. If you read the package insert, no, madam, of the ablation probe, the
Mm.
package insert for the ablation probe states that it is a tried and tested model as far as the ablative index. There is something called as how much it will ablate at what power and what is going to be the ablative radius. That is mentioned on the machine itself. Okay, and that has been it has been scientifically proven to be working on liver models of the pig. So animal models of pig liver, it has been already tested. The same thing has been extrapolated hugely in oncology. Our interventional radiology colleagues do it very effectively for liver tumors, prostate tumors. They do it very effectively for skin tumors also, deep located skin tumors and lymphomas. Okay, the ones which are not very accessible, no? So you can easily do it, madam. When it comes to the uterus, my personal belief is that this, madam, and I have a right to be wrong as far as this is concerned. Okay, my belief is this, that it is not a very easy surgery in gynecology because you need to map it out beautifully well. If you saw our live surgery, which we had shown, no, that day, madam,
Yesterday,
myself and yesterday, myself and Vismay had shown, na, it
mm.
takes so much effort of one guy to sit with that probe there, mark the entire tract out, tell the operator that you are supposed to come in this particular tract. Okay, and the operator has to go exactly in that tract, ablate exactly the amount of ablation which is required, because see, all other lesions which we are trying to study or which we are trying to ablate anywhere, no, madam, are loculated lesions. Even if you want to ablate something in the liver, it is something on the surface of the liver, something on segment 3 of the liver. It is loculated, madam. So you
Mm.
just have to put your probe in the center or somewhere close to the center and it will ablate it off. In the uterus, what happens is your arrangement of the myometrium is very, very different compared to the arrangement of liver tissue. Myometrium is a very strong tissue, madam. So in order to ablate such a strong tissue, and remember, you can't ablate the whole uterus. Basically, if you ablate the uterus, you have to do hysterectomy only. Understanding? So your field of ablation has to be so correct. It has to be overlapping. I mean, it has to intersect with each other. It has to overlap each other in all the planes of the uterus. Until you don't get that thing right, you will only go and do like a chitku. Matlab, you will go inside, put your probe somewhere, ablate for 1 minute, and you go, ablation done, come out. And that ablation will not work any which ways, madam. That
Okay.
will not work.
See, that is one aspect what you are saying. See, we are trying not to do it for a normal myometrium. You are trying to do it for a adenomyosis.
Yeah.
Where it is like, the tissue is so varied. Some are cystic, some are like,
Yeah.
very similar with the tissue of the myometrium. Some are very hard. Some have like, you have seen the chocolate material, like how it
Yeah.
was coming out and all that. So do you change the probe, the parameters, like when
Madam,
you...
we have already told one thing. For focal adenomyosis of outer myometrium, this probe has got no role.
No role. Yeah, yeah, I agree.
This we have told many, many times. I mean, you have to do adenomyomectomy, even if it is a repeat surgery, you have to do adenomyomectomy.
Yeah,
Correct?
yeah.
This will work predominantly for that focal lesion and diffuse lesion, which is causing that cavity to get distorted, madam.
Okay,
Because you don't want to damage the serosa there.
correct, correct. No, see, nowadays we are seeing like, previous 2 IVF failures, previous 3 IVF failures, and suddenly you see an adenomyoma. Okay.
Common, no?
Very common. I mean, just like, 2.5 centimeters, 2 centimeters, some are just at the fundus, some are like, deep, like how you had shown it in your diagram in case 1. So in these cases, do you think like, it really makes sense to actually do this and then go ahead with the IVF and transfers?
In my opinion, yes. Okay,
Mhm.
because this is the best way to get it done, madam. This is the
Mhm.
best way to get it done.
And what
Right?
is the max size that you can do it for?
One should not try to cross 11 centimeters, 12 centimeters, madam.
Of the uterus size, you mean?
Yeah, uterine length.
Uterine length. Okay.
Anything more than that, you have to do adenomyomectomy, madam.
See, but uterine length is not the issue here, right? It is the posterior wall of the uterus thickness, which is
But
quite...
still, madam, we will calculate based on uterine length only, no? Because that is a globally accepted parameter. If
Mm.
uterine length is more than 10 centimeters, we know medical management won't work. Like that, if it is more than 12 centimeters, I think ablation should not be done, madam.
But how do you test for the strength of this myometrium post the procedure? Because see, you are saying there should be there should be that overlap of the tissue that you are ablating so that it is like, optimally done. So
Yeah.
in that overlap areas, don't you think like which is receiving double the dose of the thermal thing, that will become weaker than the other tissue?
No, 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 no. Oh, no, no, no. That is not how the physics is. See, see, if this is the uterus, no, madam.
Hmm.
Let's assume you have primarily put your probe here, okay, madam?
Hmm.
So primary ablation has occurred here.
Hmm.
Then you will withdraw the probe a little. Let's say you withdraw the probe. You came here, madam.
Hmm.
And then the ablation radius will be like this. Can you see?
Correct.
So these two guys, no?
Hmm.
The farther you are away from the tip of the probe,
Hmm.
the lesser is the ablative effect. Understanding? So you have to be ablating it in such a manner that this concentric radius is no, they
Hmm.
don't overlap each other by more than 2, 3, 4 millimeters.
Okay.
Understanding? By
Correct.
doing that, you will save that myometrium which you spoke about.
Yeah, yeah, yeah. Done, done.
And madam,
So,
that is the reason why you should also be like how you are 5 to 7 millimeters away from the endometrium. You should also be 5 to 7 millimeters away from the serosa.
okay. But why is it not so successful in all cases? I mean, do you think it is worth giving the effort that you gave? I mean, I saw you, doing that case. I mean, you would have finished like, multi-compartment endometriosis, at least 2 cases by the time you finished that microwave ablation.
I could have. But then I think it will help, madam. Because we are starting to get pregnancies out of this, no? And see, these are all bad cases. Remember, if you start getting pregnancies in this bad uteruses, no, where otherwise people would have told, "Arey, repeat adenomyomectomy is there. Why you want to do anything like this? Endometrium will not form only. Endometrium will be chronically stuck at 5 millimeter, 6 millimeter. It will not grow only, madam, beyond that. Post microwave ablation, we have seen those endometrium grow.
Okay.
Okay.
Okay. And see, you think the serosa is so important that it will give so much strength to the integrity to the uterus, like when the uterus is expanding, when you have done this kind of a procedure on the
I
uterus?
don't believe in that theory, madam. You know,
Yeah.
actually, what would have happened is once this all is to achieve that pregnancy.
Mm,
I have told this many times. If pain is your problem with adenomyosis and uterus has to be conserved, the answer is adenomyomectomy. You
correct.
can't do microwave ablation and all that.
Correct.
Understanding? You have to be a very good surgeon to do good adenomyomectomy because pain relief is fabulous. I think
Correct.
you have seen so many of our patients in Bangalore itself post adenomyomectomy, no complaints as
Correct.
far as pain is concerned, isn't it?
Correct.
If
Correct.
fertility is an issue, you need to get something done to get that uterus pregnant because since you are not ablating off everything, this tissue is going to grow back, no, madam.
Yeah. 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 Okay. I mean, for all the fertility experts out there, so do you think, I mean, if we have to refer you cases, of course, like when you come to Bangalore, we have around 2, 3 cases pulled up. But how do we refer cases? I mean, is it like you will carry your instruments to all the locations and you will start doing and they refer like locally, like Bangalore
Yeah,
people?
we are planning to do it in all locations, no, madam.
Mm,
Bangalore, Delhi, Agra,
mm.
Ahmedabad, Pune, Bombay. These many locations. Chennai, I am yet to get approval. Hyderabad, I am yet to get approval. But all other locations, I think I am having approval.
So totally, how many cases you might have done so far? I mean, after you have started doing this in the past 2, 3 months?
Array, that probe has started apologizing to us to come to our place, you know. So see,
Okay.
we last week we did 16, madam.
Okay, that's all. Okay. Mm,
Yeah, that's all. This
okay.
week we have done two so far.
Yeah. Yeah. Good. Great. I think, I mean, we will await. I think if whatever you have been doing with so much of dedication, I mean, even if it ensures like, the fertility, whatever is better possible than the adenomyomectomy, then definitely it is all worth it, even if we can give that one extra pregnancy to that.
My best outcome will be when 3-4 of these people become pregnant with natural pregnancy.
I don't think so because see the fallopian tube is already like anatomically it is displaced because of the adenomyosis. Even if the uterus shrinks, I don't think the uterofallopian tube, whatever that anatomical orientation, I don't think it can ever be normalized with your. I don't know. I may
Don't know,
be.
madam. Don't
Yeah.
know. I mean, I don't know. If it happens, it will be amazing. If it doesn't happen, then we will see, no?
Yeah, yeah, surely. So yesterday's also you said the tube was open and like you were jumping out of joy that the tubes are patent. No, yesterday's case.
Yeah, I was not jumping out of joy. I was just screaming out of joy.
Okay, I think we have covered most of it. So any questions, please kindly put it up on the groups. I know since it is a new technology, many of you have a lot of queries and also a lot of reservations about accepting such new things. And any new technology will always come with its own controversies and prefixed notion about the usage. So I think we
I
are
had a reservation to do it for more than a year.
really.
Yeah,
I
madam, because I was speaking to Xiaoming since almost 2022 end. Okay, and I had a reservation to get it done, get it, get it in my system for almost a year. I wanted to. I spoke to 10 more people. Okay, who are also doing it in their countries, and that is when I thought I will buy it. And majority of the people who are doing it are from Korea, China, Japan, Taiwan, and Thailand.
Mm-hmm. I thought you just figured it out overnight and started doing it. Got it. It's okay. So, I mean, cost, I mean, would you mind? I mean, is it like pay per use or is it like you own the machine or you just get
I
the
am
machine?
currently owning the machine, madam, because
Okay.
I have worked out the deal like that. Okay.
Okay.
You can also get options of pay per use of the machine. I've worked out the deal where I've bought a good number of probes So what typically happens is all my software upgrades are taken care of for free, madam.
Software update. I mean, yours, like you, as in Jay Mehta or the machine?
No, machine what, madam?
Oh, sorry. So, I mean, why is it important? Like our phone?
The new probe, no, madam, which is coming inside this. No, see, currently the probe is around 1,30,000 rupees actually. Single
Okay.
probe is 1,30,000 rupees plus GST. So it comes to around 1,68,000 rupees or something. Okay. When the new probe comes, no, madam, they will now keep on getting the new probes. This machine has a very good LED screen inside with where it shows that focus of ablation, no? So the new probes which they are trying to develop, they have so much data now that they are trying to develop probes with AI.
Yeah.
How much to ablate, where to ablate, and is your location correct or not? Okay.
Okay.
So I think,
Also,
I think.
Tell me this. I mean, with one probe, you will be able to finish the entire uterus, or sometimes you
One probe entire uterus.
And can you ETO this and use it for one more patient?
No, madam.
Not really. Okay.
It goes in the uterine cavity, no?
Yeah. So
and there are microscopic pores inside, some material goes inside. It is not good, no?
Yeah. So like in ovum pickup where we enter the ovary and we try and withdraw it. So is it very similar? But I saw you poking the serosa a couple of times yesterday.
And after the ablation finishes, I'll wait for 3-4 minutes for the probe to cool down.
To take it out of the uterus?
Before I take it out of the uterus.
Okay. Yeah, sure. Okay. So anyone has any questions, please feel free to ask in our groups. So risk of uterine rupture, he's yet to see pregnancy, which is advanced till that stage. So I think he will tell us in a year's time how many ruptured, how many did not, and what's the benefit over the adenomyomectomy in terms of like risk of rupture. So otherwise, if any cases to be referred, please refer to Mumbai at this moment, or to your closest place like Bangalore, Agra, Delhi. So I think we are good. So let's hope like you put India on a global map with this new technology where you do at least like 1,000 cases in a year and give us a data. Thank you very
That
much
much
for
so
that.
we will do, madam.